Okay. Yeah, I've got a very slow meeting. Were you in the meeting yesterday with? Yes. How was it? Yeah, it was good. Yeah, I'm gonna send them the summary. Yeah, good.
Good morning, everyone. I would like to begin by welcoming everyone to this meeting of the joint Cambridgeshire and Peterborough Health and Wellbeing Board and Integrated Care Partnership at Newshire Hall. Filming and photography are welcome at this meeting, but please can everyone present turn their phones to silent or vibrate while the meeting is taking place. The meeting will be live streamed and a recording will be available to view later on the County Council's website. There is no fire alarm test scheduled for today, so if the alarm sounds, I will adjourn the meeting and we will leave by the center doors to my left. There is a fire escape next to the kitchen and we will assemble at the far end of the car park. If the meeting runs beyond 2 hours, we will take a short comfort break. Before we begin, I would like to pay tribute to former member Stuart Francis, former chair of Health Watch Cambridgeshire and Peterborough. It is with great sadness to share that Stuart passed away on Boxing Day last year. Stuart, as the former chair of Health Watch, served as an active and engaged member of this joint Cambridgeshire and Peterborough Health and Wellbeing Board from his appointment as chair in October 2021 until he stepped down in June 2025 due to ill health. Stuart contributed to the development of our joint integrated health and wellbeing care strategy that is still actively influencing this board's priorities, as seen in the papers we are discussing today. Our thoughts are with his family, friends, and colleagues. We have a permanent change in membership, and I would like to thank former member Rob Bridge, Chief Executive of the Cambridgeshire and Peterborough Combined Authority. On behalf of everyone present, I would like to welcome Andrea Wood, Assistant Director of Skills, Employment and CPCA. Would the Democratic Services Assistant report or any apologies for absence, please?
Apologies have been received from Jan Thomas, who is substituted by Pam Green, John Gregg, who will be substituted by Carrie Trail, Dr. Zoe Hutchinson, who is substituted by Erin Lilly, Jonathan Jelly, who will be substituted by Carolyn Tyrell-Jones, Councillor Katie Cole, who is substituted by Councillor Neil Boyce. Apologies have also been received from Louis Campher, Mayor Paul Bristow, Piers Ricketts, Darryl Preston, and Pam Green, who is substituted by Dorothy Gregson. Thank you.
Members, we will begin by going around the room to establish who is here and what organizations we are representing. I will start with myself, Councillor Luis Navarro. I am the Vice Chair of Cambridgeshire County Council's Adults and Health Committee and Co-Chair of the Health and Wellbeing Board.
Good morning, Sally Cartwright, Director of Public Health, Cambridgeshire County Council.
Pam Green, Neighbourhood Place and Partnerships Director for Cambridge and Peterborough for Central East ICB.
I'm Neil Moder, I'm a GP and I'm North Care Partnership Representative.
Caroline Chirrell-Jones, I'm Head of Operations with Health Watch Cambridgeshire and Peterborough, and I'm substituting for Jonathan Jelly.
Good morning, I'm Councillor Neil Boyce, Cabinet Member of Adult Social Care at Peterborough City Council.
Morning everybody, Patrick Warren Higgs, I'm the Executive Director for Adults Health and Commissioning at Cambridgeshire County Council.
Morning, I'm Erin Lilly. I'm the Director for the Cambridgeshire South Care Partnership, here in place of Dr. Zoe Hutchinson.
Good morning, everyone. I'm Paul Mead, Chief Executive at Fenland District Council.
Good morning, I'm Melanie Pittock. I'm CEO at Age UK Cambridgeshire and Peterborough, and I'm here to represent the voluntary sector.
Good morning, Superintendent Paul Rogerson, Head of Prevention here for the Constabulary.
Hello, Dorothy Gregson. I'm here to substitute for Pam today, as she's substituting for Jan. But on the agenda, there's a proposal. I take the seat that John O'Brien did previously from the Cambridgeshire and Peterborough ICB, but at the moment from the Central East ICB. Thank you very much.
Good morning, everyone. I'm Andrea Wood. I'm Assistant Director for Skills and Employment at the Cambridgeshire and Peterborough Combined Authority, representing the Combined Authority.
Good morning, everybody. I'm Grant Wilson. I'm the Chair of the Adults and Health Committee here at Cambridgeshire County Council.
Good morning, Raj Lakshman, Director of Public Health, Peterborough, representing Peterborough City Council.
We have other members online. Could you please turn your cameras on and introduce yourselves? They're not online. Okay, in that case. Does any member wish to declare any disclosable pecuniary interest or non-statutory disclosable interest? Thank you. We move now to Part A, which is we're being asked to approve the minutes of the Cambridgeshire and Peterborough Health and Wellbeing Board and Integrated Care Partnership meeting on the 23rd of January 2026. If any board member wants to raise a question on the accuracy of the minutes only, can they do so now? I see no objections, so we will take that as carried unanimously. On that basis, are board members happy to approve the minutes as written, subject to that? On that basis, the recommendation to approve the minutes is carried. And we move to the action log. Do officers of members have any comments on the minutes action log? Okay. Item 3 is the Cambridgeshire and Peterborough Obesity Charter. This report, along with agenda item 4, was included on the agenda for the previous meeting. However, as the meeting became important, both items were deferred to this meeting. Please can Val Thomas, Deputy Director of Public Health, introduce the report?
Thank you. Thank you, Chair. I'll just bring up the presentation, though I won't be using it too much. Well, I'll just try again. No. Yeah, excellent. Oh, right. Right. Obesity is obviously one of the priorities for the Health and Wellbeing Board. And over the past 2 years, we've had various presentations and updates to the board. But the thing that always stands out is the intractable rates, which really don't really change. And if they go anywhere, they go up. And I think over last year, we did draw attention to this. In 2020, back in June, the board approved a framework for action. But in October, at the Board Development Day, we said, well, why? And it came back to obesity is a huge issue. It really does need action in all parts of the system and a joined up action across the system. The outcome of that discussion was a charter which would engage different parts of the system and also asking them to commit to delivering on the charter. And I think the presentation, which I will whiz through in a moment, picks up on the reason why we need a charter and why and what it will ask of organisations across the system. So moving on, as I said, if you look at the reason why we need a charter, I think if we look at the data, I alluded to the rates, they hadn't changed at all over the past few years, both for adult and childhood obesity. and the inequalities continue to be found throughout the landscape. So I'm not going to dwell on these. I think something which has become more apparent with the focus on growth and economic inactivity is the impact that obesity has on employment. And alongside that, obviously, poverty, and then that cycle of poverty related to obesity. I think we're all very familiar with the impacts of obesity. But I think on this slide and the next slide, we actually know what to do about obesity. We know that we need to look at the environments in which people live and work and in their communities. We need to look at behaviors. But it's this working together through a systems approach. And there have been examples internationally, certainly most notably in the Netherlands and also in Milan, where systems have adopted this very joined up approach and coalesced around a charter. And it's this alignment. We have over 60% of the population who are either overweight or obese. Organizations can contribute in different ways, but it does take a whole system to shift the dial on obesity. And we've been trying now for quite a while. And the discussion, I think in October, the October meeting was very much, it was rather, somebody said it was like the elephant in the room. And now is the time perhaps to tackle it through this approach. I'm not going to go in detail because you have the presentation, but obviously like any charter, it would have principles. But I think what the ask is something about organizations making obesity a strategic priority. It's something about resources to support that from the different organizations. Great element of accountability. Equity, of course, needs to be embedded in it as well. But that key theme of working collaboratively across the whole system and across different sector boundaries. And those, obviously, those are the organizations that make up our system. It's not exhaustive. And this is the question, well, how? And there's a second appendix that came with the paper that talks to the delivery and identify delivery areas. This was our framework for obesity, which was approved last June by the board. And it identifies the scope, the priorities within the scope, and the actions for taking it forward, and obviously underpinned by policies, inequalities and equities, the poverty impacts, and enablers such as training and so forth. And then that system support for national policies. So the challenge is, how can a charter bring organizations across the system to support this? This, again, it's in one of the appendices, outlines those key elements. And it ranges from resources, I've already said, sustained action, involvement in system-wide governance of it. So all the themes which I think probably we are very familiar with. In terms of the delivery, there are 7 key themes. And obviously this is huge. The agenda goes on forever. And so prioritization became quite a key point in the discussion. And the 2 recommended areas for action were children and young people. And it's termed the workplace environment, but it's essentially, well, us in the public sector organizations, what can we do within our own space? And these recommendations arose from various discussions with stakeholders, but also very much from the SROs, which are Councillor Navarro, Councillor Ali from Peterborough, and Jan Thomas. And I think we all agreed that these were the 2 priorities that would be put forward. So in terms of summarising the Charter and what it means, I think it's intractability. I think that's the right word, intractability. If you can say ability at the end of being intractable, it's very much. It requires that kind of movement, And I think we hear the word movement quite a bit now, but I think it certainly resonates with addressing obesity. It's having a belief that we can do something about it, because there's a certain sort of, oh, well, you know, it's been around for so long, but there are examples in many places where there have been improvements. Prioritization I just referred to was the recommended areas of initial focus on children and young people, and then the public sector as an employer. And then there are some sort of, around delivery, some key themes to lever in support, particularly from academia, where they've had examples where we've had good operational delivery, and also marketing. And to have that expertise both nationally, but we also have a lot of local expertise in those fields as well. In terms of governance, to establish a multi-agency group with membership from senior leaders and the external experts to support and oversee delivery. And I think there was this focus on having senior leaders that could represent their organisation with authority. And then there's the area of leverage. The public sector does have incentives, which we could use with employers and providers and so forth. So that was also an area where we felt could be explored. So those three areas to embed it as a means for taking it forward. And then another sort of interesting discussion that came out of this was that there are synergies with other areas. And I think the example of anchor institutions was particularly named as being something where don't kind of duplicate, but look at the synergies and the complementary action. Just as an update, following on this, I went to a public service board, and again to socialise the charter in the interim period between the last Health and Wellbeing Board and this Health and Wellbeing Board meeting, and I took away from there and asked for all the district councils and other organisations there to take it back to their organisations to socialise the charter and its recommendations. And subsequently, I am now in the middle of meeting with the district councils to explore this option, as well as obviously within the county council. And I know my colleague Damilola is also doing the same thing in Peterborough with your senior leadership and so forth. And I think she would have been here today, but I think she's not. I'm not certain what's happened there. Right, I'm back. So basically asking the board to accept the recommendations in the paper, which focus mainly on supporting the charter and socialising within their organisations, and the prioritisation of children and young people and the public sector as an employer. Thank you.
Thank you, Bob. Members, do you have any questions for Val or any comments? Thank you very much, Dorothy.
Thank you very much. Val, thank you for bringing the charter. I mean, what an important issue. It underpins many personal lives, but also cost to the NHS, cost to employment, cost to other areas. I wanted to circle back to the charter, the international evidence, because that's really exciting if some places have done that. And I'm just looking at the line of sight between the international evidence and the two priorities that you picked on. This is going to be tough stuff, and we may need to widen priorities as we go forward in the future. So I'm just looking for that line of sight, Val, but thank you for bringing it through.
Yes, and I think it would be very much an iterative process, and like I always think families live in families, children live in families and communities, and it's not sort of a linear type process. Absolutely agree. And just to comment on the international evidence, I think the key message is that if you throttle back at all, then you lose the improvements that have been made, and I think that's been the experience of the Netherlands.
Thank you, Val. Graham.
Thank you, Chair. Val, whilst I support very much all the things that you've talked about the importance of obesity and the like, When we get to page 40 and we talk about the outcome measures, how can we actually support the charter if there's still a few things which are to be confirmed, or one in particular, eliminate the deprivation gap in obesity prevalence, where I'm not sure whether we can ever actually eliminate it. We can certainly reduce it. So I'd be interested in your comments about that before we decide whether or not we're going to support the charter.
Try and answer them as we go along. Yeah, okay. Well, I think it does sound very aspirational. I agree with you, but I think it's a worthwhile aspiration in reducing the gaps that do exist, and I think it's part of the task of the charter is to work through those issues, and I think that's where I think bringing together the different organisations across the system can lend itself to strengthening those areas where we do need to refine what we are attempting to do. I'm not saying attempting, which we will do, because I think we've used that word in so much with obesity. So I would say yes, they are aspirational, but the charter does go to 2045. So I don't know if that answers your question exactly. I'm not saying the charter as it is answers all the questions, but it's the direction of travel and what we do need to firm up some of the areas of it, which would be part of the task if the charter is supported.
Graham, would you like to address that?
Well,
but before you go, sorry to interrupt. Just hold the comment a second. I'm just going to let the people joining us on Zoom to introduce themselves, and then you can respond to that. If you may, shall we start with Dr. Jack Aluwaya, please?
Good morning, everybody. Hi, Jack Aluwaya, Chair of Royal Papworth Hospital. Thank you, Chair.
Thank you. Carrie Trail.
Good morning, Carrie Trail, Service Director for Education at Peterborough City Council.
Thank you. And we haven't got Liz Watts yet, have we? Okay. Thank you. Back to you, Graham. Thank you.
Thank you. So I agree, Val, that this is aspirational and it goes to 2045, but I still feel that by 2035, we should be aiming to achieve some specific outcomes. So I'd be interested in other people's views about that before we agree the charter in general.
I think for certain we do have some local targets already around obesity that are linked to the Health and Wellbeing Board priority. So I think we would have to review those and then look at that sort of longer time frame. And I do think targets need to be reviewed regularly because, and I think in a sense it depends on the level of support. If we get good support for this, when we would like to see those targets to be increased or raised. But I think we'd start with what we have already in the we've agreed with the Health and Wellbeing Board, and then look more carefully about how we could refine them.
Thanks, Bob. I move over to Paul. Paul, Matt, please.
Thank you, Chairman. Thanks, Val. Clearly, it's a really important area for us. I've got 3 points. As a representative of the North Place Partnership, we've currently been working through and reviewing our priorities for this next year and beyond, and can confirm this is something that we want to align closely with for obvious reasons. There are some significant challenges obesity-wise in the North Place area of Cambridgeshire and Peterborough. In terms of Fenland District Council, again, it stands to reason. In principle, we're supportive of this, given some of the health inequalities, historic health inequalities that our district and its residents have suffered from. I suppose, Val, fundamentally, my question is, given that at best we've flatlined on health inequalities generally, and obesity being a key part of that, what's different with this charter that's going to shift the dial so we can see incremental improvements over the period to 45? Thank you, Chairman.
Cool.
I think it goes back to what I said when I referred back to last October when it was said that what is the elephant in the room, and the elephant room being that this has obviously has so many dimensions to it. It affects all organizations can have an impact on it in a different ways, whether it be on behaviors, whether it be the environments, whether it's the workplace environment and so forth. But what we're not doing is that not all parts of the system are engaged, and also there are synergies between different parts of the system or complementary action, action that is complementary, way around, that is missing, and it's these kind of gaps that could really enhance the actions that we take. Because I think there are a lot of actions. I think you've mentioned that you're planning in Finland, and I think there are a lot of actions being undertaken, and the board has acknowledged these at different meetings. But there's still this let's say we're not making the most of our opportunities as a system. And what the charter is asking for is that every organisation in the system where possible can lever in the opportunities that they have to address obesity, and that varies immensely, as you can imagine, and then that identification, well, that complements that action and so forth. So that is the added value, and it's the added value which we've learned from international examples more than anywhere else.
Thank you, Val. Yes, and the Fenlands and Peterborough, although we have the common problems all over our counties, they show the most acute of the problems. So yes, it's very important that we do something different there. Neil, I'll go with Neil, please. First.
So Paul very well sort of said that the North Place supports obesity generally in thinking about how it can make the difference. And I guess, if you look at an obesity charter, I think what's really positive about it is that leaders around the health and well-being system are kind of, potentially supporting something to prioritize it. I think the areas being prioritized are sensible areas of the two that were chosen. I guess my challenge for myself in all of this is, well, what are the practical, pragmatic steps that get us anywhere? And I guess my experience has always been set your ambitions high, but then monitor yourself every 3, 6, 9, 12 months. Because if you set targets too far in the distance, in a way, it becomes tomorrow's problem. And obesity is today's problem. So actually, how do we make sure that in this, if we're going to sign up to a charter, that it, I think it stems from your question, how does it actually make a difference to people? Speaking openly about kind of our approach to it, and if we take it away maybe from obesity but towards activity, recently I went to a local GP vocational training scheme in Peterborough, and the question was asked, how often do you, to a group of future GPs, how often do you exercise? And the answer came back almost like we were an American law firm. It's a lot of the population there thought that there was no way on earth they could exercise because they were too busy in their training to get there. And I think part of that leadership is not just signing up to a charter, but it's actually what are we all collectively doing ourselves, to prevent obesity or to maximize activity. As an organization, we've been trying to prioritize activity and well-being in the staff. And we started by just talking about it in appraisals and just having conversations, making it part of everyday meetings and conversations. Over the last year, we've developed a health pod, which features in Raj's Director of Public Health report. And that, I guess, is a facility that our staff can use whilst at work to do exercise. And I guess, just by talking to our staff about exercise, hopefully that's positive. But actually by doing something as an organization that is for patients and public, but is also for the staff to use with trainer support, makes a huge difference. And I guess the reason I'm telling the story is because that's what it takes to make a difference. Leaders signing up to a charter is really good and really important, but actually it takes a lot of practical things. As the NHS and with social care, we are some of the biggest employers in this area. Alongside the people we employ are their wives, their husbands, their children. We can make a massive difference. And I guess what I'm worried about is that we sign up to the charter, but we don't get down to that micro level detail that makes it really hard with this stuff. But that's what really makes the difference.
that captures the spirit of the charter, that it's that sort of embedding it into everything, and it changes the cultural dial as well, and the expectations.
Thank you, Val. Yeah.
Captured, I think, an essence of the charter.
It is a political intent. The actions will depend very much on the kind of jobs that you and your organizations do. And I'll probably I'll refer actually to the environment, that green slide that Val presented. Yes, we concentrated on the first one, which was the future of children and what we can do inside our organizations. But I actually think that the second one, the community action, it's where the whole thing could really kick off, because that means ownership by the people. Now, let me move over to Neil. Thank you, Neil.
Thank you, Chair, and through you. It sort of comes back to Neil's comments. Whilst I fully support the Obesity Charter, the crux of it is we've been doing this for so many years now. What's going to change when how do we get this across to residents? We see it through COVID, especially around Peterborough, a lot of the ethnicities don't trust governments and people in authority. We found in COVID, the way to deal with that was go through voluntary sectors, community champions. What here is going to change how we get this information across to residents, because we need their uptake. It's okay us as leaders saying we want to do this, we want to do that, but if it stops at the residents, it's all a waste of time. So how are we going to change that, what we've done before, to what we're going to do now? Because we need the community to come on this journey with us as well.
I would say that most, if not all, public sector organisations work with their communities in different ways. But how many of the organisations, I think many of them do actually work with their residents, raise the issues of it, ask the questions that Neil sort of alluded to, and how do we embed that into our organisation, that when they work with communities, that this is an issue for them, and also acknowledging the challenges as well, because I think one can't escape from many of the challenges that people confront when addressing obesity. But I don't think we've had that kind of depth of working with communities on this issue. And it's a difficult issue to raise in many ways. It's a sensitive issue. And it has to be done with some degree of sensitivity. And I suppose what the ask is of the organisation is to enable, skill their staff to have these conversations, and to normalise this, saying, this is an issue for us.
Thank you, Val. Patrick, please.
Yeah, thank you, Chair. So, I mean, I think I'm back to Graham's point, really. I think there's something about the length of this and whether or not we've really done enough to define clear outcomes and metrics. We're at risk of the charter kind of becoming more symbolic rather than with any accountability. So the devil is really in the detail, and it's difficult, I think, for partners to sign up to it when we're asking for such things as resource implications without really knowing what resource implications they are and where those investments will come and how will it work and what's the estimate and how is the cost sharing going to work. Paul's point was really important, that I think the role of the district councils is not adequately addressed. They have a huge influence around many aspects of life. And, there's something in the title really about obesity. If we're trying to engage with residents, if we talk about obesity, is that the right terminology in order to engage with people and talk to people? Should we not be thinking around a different way in which it means something to us, but what does it mean to a person in the street? And how do we engage with people effectively? Is it more about well-being? Is it more about healthy lifestyles, etc.? There's a limited discussion of risk in the paper. So things around funding, engagement, the fragility of our landscapes at the moment. The ICB are going through significant churn. Many of these local authorities, we will all be going through significant churn. There's political risks. And I don't think it evidences enough to put something to 2045 without anything in between. I'd rather have one that says this is a 2-year charter, but actually get something deliverable in the 2 years rather than say it's 2025, because we can kick it into the long grass, say there's a charter, but not do anything for 20 years. And I think we've got to do something now. So I welcome the charter. It's not an easy topic. It's not an easy subject. If it was, we'd have solved it years ago. But I do think I think the charter is an overarching piece of work, but we've got to be assured what's happening underneath that charter to make this feel more tangible and move forward.
Thank you, Patrick. And that resonates with pretty much what Neil and Neil as well said. Let me move now to Pam. Pam, please.
I'll come back to it.
Thank
Answer
you.
your questions, Patrick. When
Thank you. Do you want to answer the question, Val, directly? Or
yeah, if you like. I think target setting is an interesting one, and if I came here, or if we came here with a target without going through that kind of narrative with the different organizations and getting that agreement, I think that would be difficult. And that's part of the sort of the idea of a charter, that you commit to that principle of working together. And the next challenge then is to work through, okay, these are the possible deliverables, these are the things we want to focus on, and how will that impact on the targets that we are setting. So I think that level, it's almost like the next iteration of it. And so the work that we're doing now, going out to talk to our key stakeholders, part of that is to tease out that level of detail and what would be the priority actions. There's some examples of actions in Appendix 2, but I think they need to be narrowed down further, because I actually think if you do spread it too wide, but then it becomes very iterative, as I said earlier. I think, yeah, of course, there would be risks in there as well, risks to individual organizations. Putting in a risk for a system, I would find a bit difficult in this paper. But I think your point about organizational change, I think I was thinking about this last night, in fact, and we're doing a lot of strategies at the moment. And I think there are those strategic themes that aren't going to go away, no matter what change there is in an organization across the landscape. Those poverty isn't going to go away. Some of the inequalities are not going to go away, lots of them. So it's a strategy that says these are important to us. How we are going to address them, I think, will change over time, which reflects the organizational change. But, you know, the national change, there's change all the time, but it's keeping sight of the challenges that we have with some of these public health issues.
Thank you, Val. Pam, Green, please.
Thank you. And thank you, Val. I think those of us that have been here before recognise the map that you put into the charter. It's a very multifaceted problem, and that's the reason why good people have tried to do it and solve it and have become frustrated. So this is a collective issue. I'd like to offer a little bit of hope, though. What you've heard articulated from our place leaders is that this is a priority in place. I think what we need to ensure that this is captured in our delivery plan for our integrated neighbourhood team delivery and our neighbourhood planning that we're doing together as health and local authorities with our communities. I've worked extensively as a physiotherapist in my profession, as well as a strategic commissioner with Sport England, and I think this should be read in tandem to the physical activity strategy. And I think we've got to get skillful in how we start to bring those things together and we activate our communities, because actually none of this would happen unless we have safe environments. One of the biggest things to physical activity barriers, inequality, whether that be from race, gender, or any other reason, in an area that I worked in before, was reclaiming a park, restoring the relationship with the police. That's what created the access to physical activity. So we have to take this in a multifaceted approach. And I would set the challenge, Val, to our neighbourhood teams. And all organisations will be represented in that. So that's where we ask for the risk to be managed and the differential between communities to be netted off. And we have bespoke strategies that actually reflect our neighbourhoods. And then our councillor colleagues can help with the trusted relationships as to how we deploy this appropriately. I think this is fit for what we've seen come to life through national strategies in the last week around neighbourhood planning. So I welcome it, Val. Thank you.
Yes, I think it's a great opportunity now that this fall in at the time of the neighbourhood plans. And I think we've had presentations here from the place, the places of what they're doing in the past.
Thank you, Val. Any other questions or comments? Well, I have one. Yes, I'm optimistic and I welcome the charter. I agree with Patrick that probably we should make it look positive. Can we talk about health rather than obesity? That can be a barrier, just to start with. On the pessimistic side, you cited the Netherlands and Milan, the programs in Amsterdam and Milan that were successful. They have measure of success in the beginning, but they have stalled. And the reason why they have stalled, and any programs that we do will probably at some point stalled, is because overall the problem is so complex. The reality is that we have created societies, not only in the Western world, but pretty much everywhere else, that have a perverse system. We have created a system that is designed to make us sick. Goes beyond our programs. Is the way we organize society, is how we have urbanized our livelihood, is the time that it takes us to move from work to home, is the accessibility of food, is the cost, is the marketing, is the way we produce food in the land. It's a whole circle that is way too powerful for us, our programs and our budgets to beat. We are not going to. The programs that you are suggesting, the programs that our charter is kind of covering or trying to cover, will have to come from the community. It's them that need to adopt whatever we suggest, and I strongly underline that word, suggest, to them to adopt and to do, is because it's going to be theirs. And they're going to embrace it and they're going to cherish it because it's what protects them. Otherwise, we will see the circle continuing, and we will go the way that, the city of Amsterdam or Milan will go. Marginal changes, marginal gains, and then a stall, because the system is too powerful. But we can do a lot. We can't reverse it. We have to hand it over to the communities, and we have to enable them to do what is best for them. And I have a little program that I need support for. So yes. Shall we move on? Let me just pass through this. We will move to the report recommendations. The Health and Wellbeing Board and Integrated Care Partnership is being asked to approve the Obesity Charter, senior leaders to socialize the charter in their organizations and secure sign up to the charter principles and proposed actions. C, senior leaders along the external experts to form a system-wide charter delivery group to monitor delivery, unblock barriers to ensure that there is progress, and D, to support the proposed 2 priority areas of action. I will take, if I don't see anybody objecting to that, Graham.
I assumed you were going to say, Lewis, I'll take all these together. And my comment on the first one is that you've heard around the table a number of people expressing concerns about the obesity charter as it's currently written. And therefore, I think it would be inappropriate for us to approve it. We could approve the principles behind it, or we could approve something else related to it. But there were references to calling it health rather than obesity because of the way in which residents might feel about that. There were concerns about the output measures not being complete for 2035, but more importantly, we need to identify what we're going to do now and put that in the charter. I think it's appropriate that senior leaders do socialize the charter, but we need to recognize the importance of districts in all of this and how LGR might or might not affect things in the future. So a shorter term 2-year charter might be something which we could consider. On item D, I think there are two priority areas which have been correctly identified, and we could certainly support those. But I would prefer if we could take the items separately, but Sally's got a comment on that.
Thank you very much, Graham. That probably brings this back to your comments and your questions regarding Graham's challenges to the overall.
Sorry, I'd like to talk from the voluntary sector perspective. I don't know whether Rachel's been in touch with Val. She has, brilliant. I hear everything that's being said here. However, we are talking about obesity. That is what we're talking about. When we go out to the general public, we don't want to be talking about obesity. We want to be talking about healthy and active lifestyles. So I fully support the Charter and what it means. What we need to do is ensure that we get the message correct when we go out, and that is where the community sectors, the voluntary sectors, the charities, all of us can spread that message. I've even written a note here. We need to do this within our own workplace. Thank you, Neil. But it's really important. So I think the core message is here. It's how we share that in a positive light.
Thank you, Melanie. And yes, and I actually will push back on, I don't think it's about obesity alone. We might not be obese, but we can be awfully sick as well. It's about well-being. It's about something much larger. But I'll take your point, and I think about the message. So again, we have a few ideas there. Sally, please. Sorry.
Thank you. I was going to say a really similar point actually around the charter itself is I think is about us as organisations and as senior people in organisations signing up to being committed to take action on obesity for our residents and our system and for our organisations. But within that, there may be some actions that we're agreeing to that are with residents that would have a different language and that would frame things differently. So I was going to make a really similar point. And then on the timescale thing, I was also just thinking that completely recognise as organisations, there's a lot of change, and we may not be the same organisations in 2 years and might not want to commit to the Charter beyond 2 years. But I think the ambitions that within it need to be longer term, because obesity is a long-term issue that we need to be thinking about actions that are long-term actions. So whether our organisations exist, the challenges in the population will still be there, and the actions will not happen and will not have a long-term impact on obesity within a short-term time frame. So I think we need to just think about that in the ambitions that we're committing to.
Thank you, Sally. Neil.
I just observed that the first time this item came, it was North and South presenting what they were going to do about obesity. It was then taken away because it felt like we had to have a strategic view on this issue. Part of the strategic view is that it needs to go back down to communities, neighborhoods, district councils. And so I think it's just to say this is tricky because actually at high level, of course, this is a priority, but the change can only happen in neighborhoods, in streets, in communities. And so, and being someone, I guess, that's whose job it is to try and make neighborhoods work and, things be different for our communities. The elephant in the room for me is not the charter, it's not the strategy, it's the truth is, it's about resource funding, it's about effort, it's about energy. And so actually, if we want to do something meaningful in this area, I guess what we need a commitment from the senior leaders is that actually, how are you going to therefore put in the things that enable people, communities, voluntary sector, GPs to make a difference for their communities? That's what this is really about. And actually, and I think the challenge for us then is, I completely agree. Having 20, 35 objectives, I think it's not fit. It's not fit. I think we've got to have an objective over the next year or 2 years. It's got to be meaningful. We've got to hold ourselves to account in terms of how we deliver that and how have we as a system set up the governance right for this to be achieved. So I think it's not really the obesity charter. I think we can but what's beyond that? How do we actually make neighborhoods work? And where is the resource to do that?
Thank you, Neil. So shall we move to try to vote this item by item, provided that the charter. Can we do that? So, or
I'm just suggesting, Sophie, that we could take the various items in separately rather than collectively. But I'm happy to go with whatever the chair or the rest of the board suggests. Am I allowed to do that?
okay, so in order to pass something different to what is suggested here, we will need to have an amendment. And I guess, Graham, you will be a proposer, but we will need a seconder. Is that?
Yes, I'm looking towards Neil here. But I'm suggesting that we could approve the principles of the obesity charter for the various reasons that you and I have raised, particularly that we need to have some shorter term targets on all of this.
So the amendment would be on item A, bracket A, to approve the obesity charter, to approve the principles of the obesity charter, to then refine what are the targets and names and everything else. Patrick.
Yeah, thanks, Chair. I think if we go to recommendation B, if we're then asking senior leaders to socialise the charter and kind of come back with comments, etc., that may well change the obesity charter. So to actually get the board to agree the obesity charter today, I don't think it's the right decision. I think it's right that we agree the principles of it, which is right. But I also think Neil makes excellent points, actually, and we don't do much reference to people and communities in this charter. We talk about senior leaders and our responsibility, but actually it's what happens on the ground is where it matters. So actually, I think so as we start to socialise this charter with as senior leaders, I think it will change some of the wording and the focus of the charter, and then it may well come back with a need to approve whatever comes back. But I think the principles, nobody's disagreeing with the principles.
That's very helpful. Thank you, Patrick. Now, let me refer you to the main issues in point 2.2 of Val's presentation. The charter is essentially a political statement or framework for local action that primarily serves to signal political commitment and encourage multi-sectoral collaboration. I think, going back to Patrick's suggestion, that what we are doing with approving this is along those lines. So we can change it. I believe we can after we socialize this and feedback is obtained. But I think approval now as is presented.
So just to clarify, we're going through the recommendations separately, but no amendments to the recommendations. Is that correct?
That's what I suggest on this. Graham, you and everybody else believe that an amendment is more suitable.
Well, I think an amendment is more suitable for the various reasons that Patrick and Neil have just said.
Is that right?
And I think that there's opportunities for us to amend the obesity charter with or without that.
Perfect. So we'll amend to say that we are voting on the principles, to approve the principles of the obesity charter. Is that correct? Or would you like to frame?
Yes.
Yeah.
Yes.
Okay.
Yeah.
So that is the amendment.
So amendment to recommendation A,
That's
approve the obesity charter, is amended to propose amendment to approve the principles of the obesity charter. We have proposed, do we have a seconder?
Okay. Have we got a seconder? Neil. Okay. Yeah. So now we move to are we all unanimous in that amendment? Liz online now. Okay. Oh, Liz doesn't have voting rights on this. Sorry, Liz, I'm just looking at you there. Okay, so we will not move to a vote. Will those in favor of the amendment on point A and the recommendations raised from B to D I won't go to raise hands. I think that is unanimous. So would the Democratic Services Assistant confirm the outcome of this resolution, please?
Yes, so the Health and Wellbeing Board and Integrated Care Partnership have approved the principles of the obesity charter and then follow the other approve the other recommendations as listed in the report.
Thank you very much. And Sally, you have a question?
Yeah, I just wanted to ask a quick question around what I'm hearing is that people agree in principle, obviously, and there's some work to do. And how does it land, and what do we actually want to do? So, do we want to agree a timeframe for it to come back for a further discussion on how it's progressed?
Yes, that we can take that as an action and to come back and schedule in a meeting. Pam.
Well, aren't you going to constitute the delivery committee that's going to now have to deal with that? Is that what's going to happen?
We have approved it now.
For the delivery
by vote.
committee.
That is part of the that is part of what we agreed to. Yeah. Okay. Thank you very much. Well, that was really good. We move to item 4. Is the Cambridgeshire and Peterborough Health Protection Report 2024. The report will be introduced by Lauren Hurley, Public Health Principal at Cambridgeshire County Council, and Kate Rolfe, Public Health Improvement Principal at Peterborough City Council. Thank you.
Thank you, Chair. Good morning, everyone. Introduction. So I'm Kate Rolfe. I'm from Peterborough City Council. I think Lauren has a very short presentation. Thanks, Lauren. Okay, so today we are presenting to the board the Cambridge and Peterborough Health Protection Report for 2024, which we will take the report as having been read. This report represents work carried out by partners across the system who are members of the Health Protection Partnership, a group which reports quarterly to Directors of Public Health. The partnership enables Directors of Public Health to be assured that health protection functions are in place in the local systems and are being appropriately implemented. The partnership is across Cambridge and Peterborough, and therefore the report is across both areas, whilst recognising the differences in the populations and reporting data separately where possible. This report collates data provided throughout the year to give a consolidated data set for review. The report data may be financial year 2023-24 or calendar year 2024, depending on what was the latest publicly available data at the time of writing. And Lauren and I are already working on the next health protection report.
Yeah, so obviously this is a very
If you can move the micro just slightly closer to you so people outside the room can listen to us as well.
Is that better? Yeah. So obviously this is a very content heavy report, so I'll just mention some.
I don't think it's better. Can we try the microphone next one along, please?
How's that?
That's much better. Thank you.
Okay, yeah, so it's a very big report, so I was just going to mention a few key considerations and notes. So vaccinations, so these are also going to be focuses moving forward. We have a varied story across Cambridgeshire and Peterborough, as you all know. Peterborough in particular experiencing lower uptake often, but whilst Cambridgeshire largely has higher uptake in whole, there are certainly areas of lower uptake throughout. Thank you. Okay, so we've also seen, on a positive note, some marked improvements in those areas, particularly in Peterborough during 2024, and this will continue to be a focus of work in the system, with targeted work to be done in different areas for different vaccinations at different stages of the life course. We will aim to continue to increase the profile of TB as well as a system, utilising our local TB network, recognising that this is not a disease of the past and there are multiple issues locally that we encounter with this disease. There are ongoing pressures from this locally, but we have an excellent collaboration in Cambridge and Peterborough with our TB network. We'll continue to promote this work as a group, particularly education for both professionals, but also for members of the public. we plan to consider the impact of health inequalities ongoing, as we have in this report, utilising neighbourhood working to improve the granularity of data that we have on this topic, and to target improvement programmes for those most in need. Pulling together this report has really emphasised to us the importance of collaboration in this type of work, and in Cambridgeshire and Peterborough we're lucky to have great engagement with the Health Protection Partnership within this system, something that we're keen to build upon and to maintain in the future. We will also keep championing the impactful improvement projects that are carried out by our partners and ourselves, some of which are highlighted within this report and will be a key thread through future reports. Yeah, we're happy to take any questions if there are any.
Thank you very much, Lauren and Kate. Members, do you have any questions or comments on the report? Yes, Dorothy.
Thank you, Kate, and thank you, Chair.
Dorothy, can also I ask you to move the microphone
Right,
closer to
lovely,
you?
thank you very much. Try and look over there, and I wanted to pick up the issue of vaccination and second dose of MMR, which is getting in some areas quite low. We heard from one of the members earlier that importance of working with the community, and I was just wondering if there's that sense of engaging the community around that, and if there are any examples that you can share.
I'll take that question, because obviously in Peterborough we do see issues, and we know that from January of this year there were changes to the MMR vaccination programme, incorporating varicella vaccination, so chickenpox vaccination, into the schedule. We will continue to engage with the communities. We already have our partners do access and inequalities work, which we hope will continue going into the communities where we know uptake is low. I think the data we have is valuable in looking at what parts of our population aren't taking up MMR, but we're certainly trying to engage with, and will continue to engage with, community groups, faith groups across the system. As Lauren said, in Cambridgeshire, there are pockets in Cambridgeshire where uptake is low, and we will continue that community engagement. I know we partners work very well with Dr. Moder in surgeries around Peterborough, so we definitely know the importance of engaging with, and someone else mentioned trusted people within the community. If there's any issues, we always refer to them, because they are who our community goes to for their advice and support.
Chair, if I may come back on that.
Dorothy, yes, please.
I'm wondering, when this report comes back, whether we could have a kind of fuller description of that kind of work with the community around the vaccination. It feels like a key issue. Thank you.
Thank you very much. Neil Moda.
Thank you. Yep. So I work in inner city Peterborough. The vaccine uptake there is unfortunately not where we'd want it to be. What I liked about the report is it went into a lot of detail about, I guess, why vaccine rates, for example, are not, where they should be. And I think definitely, there's been some changes to the GP contract, and so part of those changes are that there's a set level at which the WHO expects people to be vaccinated at, and that's what GPs through their quality and outcome framework were held to previously. This year there's a quality improvement approach, which is really positive, because actually what that does is it gets kind of local kind of GP practices and their kind of PCNs and their neighbourhoods to really think about, well, what are the innovative solutions that you can do, to increase your uptake. And so I think, I hope that actually the work that we've all done together over many years can be kind of boosted, I guess, by this kind of drive towards quality improvement and working together, etc. And I guess that takes me to, warranted variation versus unwarranted variation. That's a term that's often bandied around the health system. Why is there unwarranted variation? And by that, you could look at a graph of all of the practices, GP practices, and their vaccine uptake, and go, well, why are some really good and some are really bad? From my experience, it's not necessarily normally provider driven. It's that GP practices look after groups of populations, and some of those groups are more concentrated in some areas rather than others. And so I think, you know, continuing to work together, I think would be really positive, and I think you'll get more momentum from primary care, probably hopefully in the next year. I guess I don't know whether you're going to touch upon meningitis B and the current situation, because actually at the moment, lots of healthcare organisations, my GP practice has been inundated with worried people about meningitis B. The staff are worried as well about what do they do, you know, with an uptake. And, you know, I know pharmacies as well are being contacted all the time for people wanting private meningitis B vaccines. So there does seem to be an imminent kind of situation that's building over the last week.
Thank you, Neil.
And I think just to come back and say that, you know, with vaccine uptake, we have to realise it's so multifactorial. Yes, there is hesitancy, but there's also issues with access. There's issues with understanding the health system, that vaccinations are free, and, you know, language issues. We have to make sure that information about vaccines is translated into all the languages that we need it to be. So I think, you know, that's important to note. It's not just about hesitancy. There's lots of different reasons behind uptake rate levels.
I will also just add that we have had discussions recently, Kate and I, with one of our North Board members, and we are planning to bring a presentation to the group to discuss some of these key issues that affect particular areas. And I think it's also really important to have that represented in our neighbourhood boards as well. Like you said, you can't look at the county as a whole and look at GP uptake, which is unfortunately often how we get data on these topics. And we can't look at that too broadly without having those local conversations, and that will be planned.
Thank you very much. Paul and then Patrick, please. Thank you.
Thank you, Chairman. Well, it's good to see Neil and I have a telepathy with us, between us, sitting on North Place Partnership, because equally I wanted to reference the recent meningitis B outbreak in Kent. So thankfully it appears as though it's been sort of restricted to that area or contained within that area. But Neil's absolutely spot on. Already I'm hearing quite a lot of concerns from residents, and you know, we're not sort of directly sort of interfacing with people on health issues, but our residents, customers are raising concerns about meningitis B. So I suppose, given this is a sort of a retrospective reflection, it isn't going to sort of pick that up. But obviously we're here and now with this outbreak. You know, hopefully it is contained and it sort of goes away. But I suppose my question, building on what Neil said, is how are we kind of assessing that risk? What more might we do? Do we need to do to be cognizant of that risk? Indeed, if it sort of spreads and it sort of appears within Cambridgeshire and Peterborough. Thank you.
Well, the response to these sorts of incidents are, sorry, I can't look at you and look at the thing. The response to this sort of incident is dealt with by the UK Health Security Agency, so they lead on this response, and we work very closely with them. We have great levels of communication, and we are confident that if we had any local issues, we would be aware, and we would feed into the response on that front. I think in the long term, meningitis B vaccination is not recommended at the moment for adolescents, and there are, when it was introduced in 2015, there was the usual JCVI due diligence done on evidence to support that. But one thing we can do in the long term is to promote uptake of the meningitis vaccination that teenagers do receive, which is the MenACWY vaccination. And there are pockets of Cambridgeshire and Peterborough that have lower uptake than others. And that is, you know, meningitis, there are many groups, and this is just the incidence in Kent. It just happens to be meningitis B, but it is important that parents and adolescents know that the risk of meningitis at university can be reduced by having the MenACWY vaccination. Does that answer your question? Yeah.
Thank you, Patrick.
Yeah, thank you, Chair. And I appreciate that this is a 2024 because it's when the data is available. I'm just thinking ahead into local government reorganisation, and I can see that we kind of categorise things as Cambridgeshire and then Peterborough, and on one of them, I think it's around TB, that is broken down into the districts. I just wonder whether the same level of detail we could incorporate so that there's a helpful insight as we start to do our discovery work around local government reorganisation of the different challenges that we're facing, because we kind of categorise it together as Cambridgeshire, it becomes, you can lose some of the detail that you get from the district level information. Thanks.
Yeah, noted. And unfortunately, we are beholden to the data that we receive. But where we can, we try to show the district level data that we have. And your comment about it being 2024, yes, we're already writing 2025s, and we hope that it will be slightly more timely. This was the first report since 2019, so we're hoping this will kind of act as a baseline for us to build upon in the future. And we hope to get the next report to Health and Wellbeing Board soon. Thank you.
Thank you very much. And any more questions, comments? I've got one. The report recognizes misinformation as a factor, but provides no analysis of its cultural dimension. It's modern social media dynamics or how the system plans to fight it or address it. So do we understand how misinformation is spreading locally? And do we have a strategy or capability to deal with it?
I think data collected for that kind of insight is quite sparse, actually. And this being 2024, I think we were only just starting to have those conversations as well. Whereas I think there have been a few publications for 2025 nationally that have addressed this kind of topic, but it's definitely something we can take into account for the next report and look into ways where we can start to measure this locally. We can specifically talk to our comms teams to discuss that with them and see if they have any insight.
Thank you. We will move to the report recommendations. The Health and Wellbeing Board and Integrated Care Partnership is being asked to A, note the contents of the Health Protection Report 2024, and B, recognize the specific health protection issues and future priorities. I will take that we are happy with this, to support these recommendations unanimously, unless anyone indicates otherwise now. Okay. Would Democratic Services Assistance confirm that the outcome is unanimous and no objections? Thank you very much, Kate and Lauren. And I didn't say thanks to Val earlier. Thank you, Val. She's busy now. Okay, we move to item number 5. Item 5 is the update on achievement towards health and well-being integrated care strategies priority 1 goal. This report will be introduced by Richard Merrick, interim consultant in public health in at Cambridgeshire County Council, and Gemma Rigrock, public health team leader for children and young people at Peterborough City Council. I guess Gemma is not here. Okay, so back to you, Richard.
Thank you very much. I'm just sharing some slides to talk through, just to pick out some highlights from the paper and the data pack that's already been shared with you. So this paper gives an update on achievement towards the health and wellbeing and integrated care strategies priority 1 goals. So the overall priority is to ensure our children are ready to enter education and exit prepared for the next phase of their lives. And within that are the 2 main goals, the main outcome measures, to increase the proportion of children who show a good level of development by the end of reception, and to reduce the proportion of people aged 16 to 17 years who are not in education, employment, or training. And simultaneously to focus on reducing inequalities in both these goals. So the data that's been provided gives the picture of progress over the last few years against these outcomes, and then focuses on kind of a high-level view of key inequalities in these outcomes. So overall, good level of development is improving over time in both Cambridgeshire and Peterborough. And while Cambridgeshire is statistically similar to the England average, Peterborough is statistically below England, but improving. And as I will go on to show, inequalities in this outcome are evident across different demographic groups and groups by other characteristics. And it's important to note that the data here is high-level summary data, and so what it doesn't capture is where there may be additive effects of where individuals fit within more than one of these categories. It's also worth noting, as highlighted in the paper, that as part of the national Best Start in Life strategy, the government has set targets for local areas for their achievement against good level of development. This is for 2028 and beyond, both for all children, but also for those who are eligible for free school meals as a marker of low income status. So in terms of those targets, they're given here and in the paper, and you can see where both areas were in the last year for which we have data, which was 2024 to 25. So the target in Cambridgeshire is for 75.5% of all children to achieve GLD and 49.5% of children eligible for free school meals. And in the last year in Cambridgeshire, the data was 67.6% for all children and 45.1% for those eligible for free school meals. And in Peterborough, the targets are 71.3% and 59% for those eligible for free school meals. And in 24-25, the achievement was 65.3% for all children in Peterborough and 47.9% for those eligible for free school meals. So although we have seen improvement in recent years, that sets out clearly where we were in the last year with available data and where we're trying to get to for both areas, and recognizing the difference for those eligible for free school meals. In terms of some high-level view of inequalities and variation in this outcome, these maps here with Cambridgeshire on the left and Peterborough on the right show at a middle super output area level, show the variation across our areas in terms of good level of development at the age of 5. And you can see quite clearly quite a big range between areas performing in around the 50% or 50s mark up to the 70s and 80s, but capturing there the variation within our population by geography. And in terms of some of the characteristics, there's more evidence in the data pack, but just pulling out some of the key ones. As mentioned, free school meal status as a marker of low income status. Again, nationally, those children eligible for free school meals are less likely to achieve good level of development, and data is often reported in terms of the gap between children with and without that eligibility, and the gap in Cambridgeshire as a whole is 27%, and in Peterborough is 23%, and for both areas that's higher than the England average. And within the data pack, the variation in this gap between the districts within Cambridgeshire highlights that the largest gap is seen in South Cambridgeshire and the smallest gap is seen in Fenland. There's also variation in this outcome by ethnicity, and locally what we see is that black children in Cambridgeshire are below the England average in terms of GLD, and in Peterborough, white children are below the average, the national average. In terms of those children with special educational needs and disabilities, although with both areas, the picture is similar to national, again, there is the stark difference that only approximately 1 in 5 children in Cambridgeshire with SEND and approximately 1 in 4 in Peterborough reach good level of development, compared with approximately 3/4 of children without SEND. Whether or not children have English as a first language makes a difference, although local gaps are narrower than national averages. And it's important to reflect, in terms of what is being assessed, that it is being assessed in English, irrespective of the length of time a child has been speaking English and whether or not it is their first language. And a well-known and persistent gap nationally is that girls outperform boys. And again, the data for that locally is presented, but this gap in general does narrow as children get older. And moving on to the second outcome of those young people aged 16 to 17 who are not in education, employment or training. This figure shows the change in rates over recent years, both nationally and locally. And although Cambridgeshire is below the England average, Peterborough is above the England average, but we have been given indication that there may be some issues with data for Peterborough on this indicator for 24-25. So there is some degree of caution in interpreting that particular year's data. But in terms of the overall trend, what's been seen nationally since 2020 is a rise in this indicator, whereas locally in Peterborough and Cambridgeshire, there was initially continued decline in this indicator. And in some terms of some of the inequalities alongside this indicator, there again is variation at a district level, with the highest rates in Cambridgeshire in Fenland being similar to Peterborough levels, and significantly lower in South Cambridgeshire. And again, there are some variations by sex and by ethnicity. And a key one to note is the impact of special educational needs and disabilities on a young person's likelihood of becoming NEET. So the paper provides some detail about work that has been ongoing and is currently underway to improve these targets. And just to pull out the highlights, one is around the work of the Healthy Child Programme, which is an integrated service across Cambridgeshire and Peterborough. And as one of the various mandated checks universally for all children, there is the 2 to 2.5 year health and development review, which is a key opportunity to identify children who may be facing challenges in achieving school readiness and achieving good level of development, and connecting those children and families with appropriate support to improve their development. And so the paper details some of the work that's underway in terms of service improvement, focusing around ways to improve the prioritization and targeting of low-income families and improve access arrangements, both in terms of booking and translated materials, to ensure that we can drive improvement and really address that gap in terms of the FSM gap that we see. This sits alongside the much broader strategic work around the National Best Start in Life strategy. And again, the paper details the new arrangements in Cambridgeshire and Peterborough, which reflect really strong partnership working across the system between local authority, education and health, in order to deliver on the new local delivery plans, which are being published this month. And I would particularly note, from a partnership point of view, that on the Cambridgeshire side, the new Best Start in Life Partnership Board is jointly chaired by the Director of Education and the Director of Children and Young People's Services from Cambridgeshire Community Services, NHS Trust. So really joining up across the system there. I would also note, as already mentioned, since this paper was prepared, the new national guidance has been published for neighbourhood health plans, and it's really important to recognise that in there, as a priority group, are children and young people, and there is extensive coverage of Best Start in Life strategy and the need for local neighbourhood health plans to align and work in partnership at a local level to achieve those objectives. In terms of work in the NEAT space, the paper highlights the combined authorities' plans to develop a NEAT strategy for 14 to 25-year-olds, very much building on the work they've been leading recently in terms of the Youth Guarantee Trailblazer, for which funding has been secured for the next year, as I understand it. And the paper also highlights or reminds the board about the Employment and Health JSNA, which was brought late last year, which included evidence and recommendations about some of the factors which lead young people to to not be in education, employment or training, and what some of the drivers of that might be in terms of opportunities to intervene earlier and more upstream. And one of the aspects we've already covered is SEND, and another highlighted in there is the role of mental health. Again, just highlighting the connection there with the work ongoing locally in terms of a review and redesign of children and young people's mental health services, an update for which was discussed at the last board meeting. The paper includes various recommendations, but pulling out the key ones which I think reflect the kind of opportunities in terms of partnership working. Again, as just noted, highlighting the opportunities to really build on the local collaboration around the Best Start in Life programs and the opportunity to really engage with this in neighbourhood health plans. Again, noting the caution that given the priorities to date have been very much about particular adult cohorts, it's really important that we get this right moving forwards in developing the plans under the oversight of the Health and Wellbeing Board. I've touched a bit on that need to focus in on families, low-income families, in terms of improving access and provision of services. And again, the recommendation here sort of asks that wider question about initiatives on poverty and income maximisation to support children and families, and the opportunities to use data which we perhaps hold separately across partners in the system, where we need to collaborate and to share data appropriately in order to identify and connect people with services to meet their needs. And again, this is an area with opportunity to bring forward in our local neighbourhood plans. And finally here, under good level development, noting those particular inequalities that have been highlighted and the need to recognise those in how we plan and deliver services locally. And likewise, in terms of recommendations under the NEAT outcome, looking for that collective support for plans for a local strategy, and also considering what member organisations can do in this space, given their respective roles. Thank you very much.
Thank you, Richard. Are there any questions or any comments on this report? Okay, please.
Thank you very much. Really welcome this, and welcome the kind of knitting that you've done of the various different strategies. I want to just suggest an additional one, which is the Get Cambridgeshire and Peterborough Working Plan, which, whilst predominantly focuses in an adult space, is the destination that a lot of our children and young people are moving towards, and the ambition for the combined authority to lead the development of what members have decided to call it a youth employment strategy, actually, rather than a NEAT strategy, certainly will lean into that space. The other point I just want to make for broader members and for minutes is that whilst the NEAT issue is very strong around 16 and 17-year-olds are 16 to 24-year-olds across the region. There's over 15,000 young people in that pool that are currently not in education, employment or training. So that represents about 14% of the age cohort. So it's an issue at 16, 17, and it gets bigger once they fall out of statutory services. And one of the key recommendations that's emerging out of the youth guarantee work is that the combined authority would potentially become the statutory body responsible for tracking, monitoring and supporting 18 to 21-year-olds beyond that. So we're currently exploring what that could look like. So really welcome this, can really see clear alignment with the work that we're doing. And obviously, health is key for young people. It's a key reason why young people tell us they are neat, actually, especially mental health. So look forward to seeing how this develops. Thank you.
Thank you, Andrea. Let me move down the list. Erin, are next. Thank you.
Thank you, and thank you for the report. Really, really thorough is probably the right word. I just wanted to confirm that kind of commitment around place and picking up through the neighbourhood work, and perhaps highlight a few examples of that. So really conscious that, and actually for all the papers we've discussed so far, but it comes out quite strongly in this, that even when we group it at district level, we lose sight of some of the detail and where we should focus, and particularly in the south. And so the work that the public health team have done recently on exploring how we kind of cluster LSOAs around those children eligible for free school meals has been really, really useful for us to start to think about where those children live and where those families are. And keen that we pick that up through our neighbourhood health plans in the south. I don't think I quite realised until I saw it in the papers that the target for children eligible for free school meals in Cambridgeshire is less than half, if I've read that correctly, and that does not feel ambitious enough. That's probably set based on where we're at now and what we think we can do, but something for us to kind of keep an eye on and think about how we can be more ambitious. SEND assessment delays didn't come out very strongly, unless I missed that in the paper, and the impact of that on those children of those waiting lists, but also their families. And so one of the things that my neighbourhood team are testing next week actually is a community appointment day for the families of those children who are on the waiting list, to look at how we can support those families to wait well, and recognising the employment impact of parents being unable to work or unable to work as much while supporting their children. So that will be a bit of a test and learn, but really keen that we keep building on the learning from that. And equally have used some of that data that I referenced before, and you've referenced in a funding application, to think about how we can take that more household approach in supporting families in North East Cambridge, around children coming through, being ready for school, parents being able to support them, and trying to bring together some of the amazing voluntary sector partners who are doing work in that patch, but doing it on what they're funded to do with their cohort, and looking at how we start to bring that together. We may not get the funding we've put through for, but we've got a pretty good plan now to keep kind of submitting for funding. So I think that's something we're quite committed to trying to pursue, and then spread and share and learn.
Richard, yes.
Thank you. Just very briefly, just to offer my support and thanks for the paper. It's difficult in this forum for me not to make the same generic statement about everything of one of support, but we, from a policing crime and disorder perspective, many of the themes in this paper, and indeed the last presentations, boil down to key root causes within antisocial behaviour. We are delivering quite an ambitious antisocial behaviour action plan, which is Home Office directed over the next couple of years. We have funding and resources around serious violence, knife crime reduction. The neat part of that is really, really important. So Erin and John and I are in advanced talks about how to deliver and be involved in that place delivery. but also we can carry those themes over into the CSP work as well. So again, it's a very generic level of support and understanding, but this is really important, and the health part of it equally so. Thank you.
Thank you, Paul. Richard, would you like to touch on the comments from Erin and Paul?
Thank you. Yes, just quickly. Thank you very much. Certainly, bothly for the support. Just to quickly touch on the target around achievement for children eligible for free school meals that's been set nationally is the one that's reported in the paper, but I perhaps should have highlighted that locally we have much more ambitious targets. That was purely reporting the statutory targets that have been set for us, and that doesn't represent the local ambition, if that makes sense. But again, the challenge very much is closing that gap and really, really supporting those children and families. And yes, the paper didn't speak to some of those other aspects around the wider situation with children with special educational needs. And you talked about sort of delays in the pathway as it exists currently. And again, many people will be aware of the recent white paper that was published with lots of plans for changes in that space and in that process, and in what kind of support is available according to what thresholds. So again, there's going to be lots of work going on in response to that. Thank you.
Thank you, Richard. Yes, I was going to ask precisely, at least I was going to leave send aside, you spoke about it, but on the free school meals, poor as they are, is better than no meal at all. And I didn't see the specific timelines or quantified near-term outcomes. And it'd be useful to have those if we have them and they're more ambitious than the 2030, mark that we have set up. We have, I think, probably rapid cycles that we could implement for this coming year, and that would be good to see them. I have Neil, please.
Thank you for an excellent paper. I guess one of the challenges that we have in our system is, previously we had a children's ABU that was very focused on bringing health and care and the social services together, the council-based services together, and obviously that was dissolved. And I guess the risk there is that then, without something monitoring it and doing the active work, you get the really good work that you've described, from the mayoral end, from the council end, and Erin's described bits of health that are doing things, but you lose that overall coordination, you lose the accountability, you kind of, and I guess my worry overall with the 10-year health plan, with the move to neighbourhoods, is that I think neighbourhoods could be the answer for everything, and it could be the solution to nothing. Because I think if it just is that actually all of these changes are going to be delivered by better neighbourhood working, by with your communities and things like that, I guess we've got to take stock that we as a health and wellbeing board, we as a system, have got to move on the neighbourhood agenda. The neighbourhoods as we know them in 2026 have got to be different to the neighbourhoods as we know them in 2030. Nationally, there is a lack of guidance, there's a lack of national commitment towards, improving the neighbourhoods, which I guess in a way is helpful because it leaves it to us, in our system to make the changes that need to happen to make all these things work. And so I guess it's not really necessarily a question for you as the author of the paper, but I think it's an observation again for ourselves as a health and wellbeing board. Actually, what are we doing? If the answer is neighbourhood to most things, what are we doing as a health and wellbeing board to actually push forward the neighbourhood agenda?
Thank you, Neil. I don't know whether Richard, you want to answer that, or we move to Pam, and because that's probably a broader question, Neil. That we might discuss a little later.
Yeah, I think that's a broader philosophical answer that we need to give you, Neil, and engage you and colleagues in, because the development of the neighbourhood plan that we will sign off through here is absolutely about articulating what that commitment as statutory and non-statutory organisations will absolutely be. So I think help shape us, get the right delivery into neighbourhoods, and that's incumbent on everybody to make that work. So and we're sharing as directors of public health and myself the leadership on that, so that it is cross organisational. But we will bring that obviously to you. And this afternoon we have a development session which will help develop some of those ideas. But I think you're absolutely right. Neighbourhood could be the answer to everything. And if we don't put some boundaries around it, we will seek to fail. And it must align to the priorities. My actual point was going to be, if I'm able to make it, Chairman, is having spent the afternoon in the youth hub at Peterborough football ground last week, and seeing how amazing the connection is between our organisations, and enabling that group lost to the system to come and seek help around their health issues, as well as combining their access to work, education, everything else. We've already got an incredible exemplar with Workwell, linking into all the things, Andrew, you've talked about already. So let's not think we haven't started to move that dial. The question is how we spread that, learn, scale, those sorts of things. And again, my stock answer has to be neighbourhood. But those central tenants, we have to enable a level of access for those sorts of things that are going to talk to your paper, Richard. So again, that's the challenge to us, is how do we take that good idea and make it accessible to more that need it? So we're not starting at zero with these things. There's been some excellent work already gone ahead.
Thank you, Pam. Dorothy, yes, please.
Thank you. Neil touched on the accountability, the kind of governance arrangements driving this forward. And I think you said that there was chairs across the NHS and local authority. I just wonder if you could say a little bit more about those accountability arrangements. As you say, this is very helpful for understand where we are in a point of time, but it's like seeing it through the rear view mirror. A really strong QI approach, quality improvement approach, is going to be needed to, you described it, each quarter, where are you? Have you done what you said you were going to do? Did it have the impact? I'm just wondering where that happens.
So as what's described in the paper, this is focusing on Best Start in Life specifically.
Best, because it would have description that combined authority are going to do that role for need. It's the Best Start in Life, the one that I'm wondering about.
Yes, and so that's where, as part of developing local delivery plans in accordance with the national strategy ambitions. So in Cambridgeshire, a partnership board, a Best Start in Life partnership board, was inaugurated last month, and that's the board I was referring to, that's co-chaired by our service director for education from Cambridgeshire County Council and the director for Children and Young People's Health Services from Cambridgeshire Community Services NHS Trust. And that's where, again, that's where that work for Cambridgeshire is going to sit. And so under that, the paper details 4 work streams, one of which is improving health, which is led by a member of the public health team, and other the other streams, I think, are education, family hubs, and data, digital, and communications. And again, I think reflected in the paper is a real focus on those disadvantaged children. So be that those eligible for free school meals or those with special educational needs and disabilities. So again, that sort of cuts across all the work that's being delivered through that partnership board. In terms of sort of perhaps broader governance, that obviously sits within other kind of governance arrangements at a county council level. I think there is still perhaps a bit of an open question more broadly about high-level governance for outcomes for children that properly spans the system and the partners. And again, I think that's perhaps an area where there is a live conversation about that. But I think it is seen as hugely beneficial that this focus through the strategy comes to the board here, which again is another opportunity for the kind of governance and oversight that you describe and for partnership working. But I'm happy to let others add to that if they would like to from a governance perspective.
Thank you, Richard. Sally, yes. And Andrea.
Yeah. I was just thinking as Richard was talking then around where this report is making recommendations and having that really clear oversight on these indicators. Obviously, we want to see them here at Health and Wellbeing Board, but the really sort of challenge conversations around the improvement against those measures and the recommendations that are being made here, are we assured that that sits somewhere? And is it the Best Start in Life boards that we're thinking that that is where that should sit? Or does it need a bit more thinking? And that's not really a question for Richard. That's just a thing out there question.
Okay, good. Well, those organisms will think about that one. It's a good question, Sally. Andrea, and yes, I'll move forward because we are behind in time.
Thank you. Just a quick consideration about the involvement of the combined authority in the Best Start for Life partnership group, mainly because of our mayoral responsibilities around reducing health inequalities, responsibilities for place, the connections to NEAT as we've discussed, but also our responsibility for skills and employment, and the fact that we have a devolved adult skills fund that delivers provision to adults from very deprived communities across the region. We've got about 12,000 adults who may have children, who may benefit from broader awareness whilst they're in learning. So if they're taking part in skills provision, such as an English class, a maths class, or even a class to support their broader employment, there's an opportunity there to reach the parents of these children that we're talking about as well. So I'd be happy to pick the conversation up offline about how we can integrate into that partnership discussion. Thank you.
Thank you, Andrea. We'll move to the recommendations. As there are numerous recommendations, are members happy to approve the recommendations as set out in the published report? Okay, then the Health and Wellbeing Board and Integrated Care Partnership is being asked to note the update to the accompanying appendix on progress towards priority 1 outcomes, which are the good level of development and need, and the rest of the recommendations in section 3.3. I will take that the board is happy to support these recommendations unanimously, unless anyone indicates otherwise now. Good. Food Democratic Services Assistant confirmed that these are being approved. I think I'm going to suggest a 5-minute break at this point. I said that we were going to have one at 2 hours, but we're slightly behind in the agenda. So if we take a 5-minute break and we resume. Thank you very much. We need you, Pam, to be quorum. We are... Welcome back. Item number 6 is the cold, damp, and moldy homes joint strategy needs assessment. This report will be introduced by Kate Parker, Public Health Principles, Social Determinants of Health at Cambridgeshire County Council, Ian Green, Public Health Service Manager at Peterborough City Council, and Liz Watts, Chief Executive of South Cambridgeshire District Council.
Thank you, Chair. Can you hear me okay?
Yes, we can. Thank you.
Great. Sorry, I can't be with you this morning. I'm at a conference in Surrey, and I will be very brief because my colleagues are going to do the presentation. But just to frame this report, it's part of priority 3 of our health and wellbeing strategy, which is to reduce poverty through employment, skills and housing. And this is the housing element, for which I am the SRO. So work to develop this JSNA has been very inclusive and collaborative, involving more than 50 frontline colleagues from local government, the voluntary sector and health. Kate will talk you through the detail, but I mainly wanted to thank her for steering this very complex piece of work through so diligently. We have more to do. We've already drafted an action plan, but I'll hand over to Kate now to talk you through the detail. Thank you, Chair.
Thank you, Liz. Kate, all to you.
Thank you, Liz. So we were hoping to be joined today by our colleagues in the Changing Futures team who were going to actually start with a testimonial. So I've just been passed the testimonial. So if you, with your permission.
Kate, I'm sorry. I think your microphone is a bit dodgy.
Is it? Can we try this one? Is that better?
That is much better. Thank you.
Lovely, thank you. So I'm just going to read this testimonial out for you all before we start with the presentation. If you just bear with me though, because it is the first time I've actually kind of received it, so I'll just see how we go. So the moment I shared a house which was with 3 other men, I lived there for 4 months. I rented through the council from a private landlord. I use an electric heater to heat my home, and it's a hassle to contact the landlord to switch on the heating. He controls the heating via his phone. I also wear extra clothes if I get too cold or put the jacket on. Failing that, I get into bed. I get help managing my bills from my family, which is difficult when they live in Scotland. I get stressed out because I know I'm going to be cold, and I have to use the limit, the amount of time I use the heating. This is all to do with costs. It's made me feel very helpless and stressed out. However, I've got early stages of COPD because of the damp and mould. This is not in the current place that I live, but I've spent over 20 years in prison and have slept rough, and I suppose it takes its toll. If I have to continue living in mouldy, damp environment, my health isn't going to get any better. I don't have a budget and strategies for need, but I feel lucky I have my family to advise me. I've had to cut back on food over the winter and relied more on handouts and donations. Think I have my own pay-as-you-go meter, I'd be more in control rather than have the heating dictated by somebody sat in a warm home using their mobile phone. I try and exercise a lot, I go for long walks, anything that fills a bit of time that doesn't cost money and helps me keep warm. Also helps me keep my mental health stable. I've tried complaining to landlords in the past and know others have as well. But we've had to deal with the attitude that if you don't like it, there are plenty more people out there looking for a room and nobody's forcing you to stay. I think you move into a property or a room which has mould and damp, then there are grants available for the mould and to be treated. The grant can be paid direct to the landlord for completion of work. To be honest, I've had very little help since I left prison, and the help I have had has been from charities. So I just wanted to start with that because I think that really shows you the heart of the lived experience voice that we've really wanted to put throughout the whole of the JSNA. If you just bear with me now, I'm going to actually sort out the slides. So the techie bit now. Okay. Brilliant. That's worked. Thank you so much. Before I just move on, I just want to again say thanks to Nick Shepherd, who couldn't be with us today. His work with the Changing Futures team and the lived experience voice was absolutely incredible, and it really has helped. So it's sad that he couldn't have presented that himself, but I do want to just kind of offer my thanks to him and all the work that his team's done. So the Housing and Health Steering Group, which is a subgroup of the Cambridgeshire and Peterborough West Suffolk Housing Board, conducted a prioritisation exercise using the criteria that you can see on the screens in front of you. The exercise identified fuel poverty and cold homes as an area of focus. It presented opportunities for system-wide action and sustainability with strong evidence base around the energy efficiency improvements and opportunities to better use data to identify those that are most in need. And you can see from the slides, we conducted quite a number of methodologies to kind of create this collaborative approach to the work. So we had the oversight of the multi-agency steering group, but we conducted 2 stakeholder workshops, the first one in October. The purpose of the October workshop was to test the focus of the JSNA, check that we'd got it right. And then the second workshop was in January. We shared the findings of the JSNA at that workshop with stakeholders, and then we also refined the recommendations, and they have been through further development after the stakeholder events. And then, as you've heard, we've also incorporated an appreciative inquiry approach to some of the lived experience interviews that we conducted. And this slide here just shows you the range of partners that we've been working with on this JSNA. So just moving on in terms of the local context, in Cambridgeshire and Peterborough, it's estimated that 34,736 households were in fuel poverty in 2023. 15,000 homes estimated to have damp, and the prevalence does vary by district, with Fenland and East Cambs having the highest estimated proportion of households in fuel poverty. Fuel poverty shows us who's at risk. Cold and damp conditions show us how that risk might play out in real life. And fuel poverty doesn't occur in isolation of other socioeconomic deprivation. For those living in fuel poverty, they often face overlapping challenges such as food insecurity, overcrowding, and digital exclusion. And these can often compound their mental and physical health. So this very busy slide is a competition with Val's obesity slide. What you'll see from the slide here is I've highlighted in the red is all the cold and damp fuel pathway that impacts on people's kind of health. It illustrates how complex the relationship is between housing and health. And what the diagram emphasizes is that housing is a core health infrastructure. The conditions people live in shape their health every day. The diagram also highlights how cold, damp and mold drive multiple health risks. Cold homes worsen respiratory and cardiovascular conditions. Damp creates the perfect conditions for mold, which can trigger asthma and other breathing problems. These issues interact with overcrowding, poor energy efficiency, and low income, creating a cycle that deepens inequalities. We also extrapolated from national estimates and calculated that treating illness linked to cold and damp housing will cost the NHS in Cambridgeshire and Peterborough 23.8 million. So just moving on to the next slide. So this is one of the slides in the JSNA pack, which just first shows you the fuel poverty side. As I've mentioned before, we've got 34,750 households that are estimated to be in fuel poverty in Cambridgeshire and Peterborough. And it's not evenly spread across our districts. So whilst Fenland and East Cambs have the highest estimated proportion of households in fuel poverty, you can see from this slide, Peterborough and Huntingdonshire have the largest population numbers. And that neighbourhood level of risk can cluster. So we can see households that are in rural areas with off-gas heating, and at the moment that's very kind of pertinent and in the press with those households that are dependent on oil fuel only. And the government's announcement earlier this week to support those with fuel poverty in those scenarios. And then you've also got the urban areas that are at higher concentrated rate of private rented sector housing. And so just moving on now to the slide that's around damp and mould. So these slides look at the scale of damp and mould and the number of homes affected in Cambridgeshire and Peterborough. National data in 2023 reported 5.3% of households in England were affected by damp and mould, which is the highest in 5 years. Nationally, damp was found to be more common in private rented households. Again, the number of homes and the proportion tell us different things. We've got 15,000 homes estimated to have damp problems in Cambridgeshire and Peterborough, with higher rates than the East of England average in most districts, with the exception of Cambridge City. What's important here is to understand both the number of homes and the proportion. These differences help us understand where to target the volume of need is and where the risk is most concentrated, supporting service planning and targeting interventions. So the next slide is around the lived experience themes that we received for having conducted 55 interviews across Cambridgeshire and Peterborough residents. So we've grouped these into themes, as you can see. So we've got daily life and coping mechanisms came through, which is around, some of the things that were reported to us were around rationalising energy use. So heating one room only, and we heard from that case study, he was heating one room only, or very quickly at high bursts, which isn't the actual best way to heat. And then you've got difficult trade-offs. People are having to make those choices, whether to heat or to eat. The other categories we found was financial burden and practical challenges. Most people were forced to make difficult trade-offs in daily living versus essential needs, so food and medicine. And most struggled to balance their health conditions, needs and energy costs. We also had the emotional, mental impacts coming through. Almost all stated that the energy bills negatively impacted their emotional health. Some rely on their personal support networks and family and friends, but some were very frustrated and tired and angry with ineffective landlords. What we've done with this particular slide is overlaid the recommendations so you can see how we got to those recommendations, which I'll come on to on the next slide. But I wanted to end this slide with some positive feedback. So those that were receiving support, some now live in warm home and they can afford more energy to heat and eat. Some have learnt new skills such as budgeting, and some have been seen that they're living in improved housing conditions. So just moving on to the recommendations now. So I'll just talk you through each of these recommendations so that you've got a bit more of an understanding of how we've got to them. So the first one was strengthen the system-wide governance and delivery on fuel poverty homes with damp, mould and condensation. And we saw from the actual process that we've taken to do this JSNA that steering group and collaborative working was the best way to get the messages and understanding of what the issues are. So we're suggesting here that we do need to continue with this coordination. The second recommendation is around improving data collection, sharing and use to enable more focused and joined up action on fuel poverty homes with damp, mould and condensation. We need to understand where we are locally. So we have to, as you can see from the JSNA, a lot of the information has been extrapolated from national figures. Where we need to be now is to be able to identify exactly where those communities are that are in damp and mould conditions or experiencing fuel poverty. The third recommendation is around strengthening current energy efficiency interventions, using data to prioritise the uptake for those who need it most. And that is, again, the importance of identifying that local data so we can make sure the interventions go to the right people. The fourth recommendation actually took some time to kind of get to this particular language, and I suspect it will need some more refinement. But it's early identification and providing holistic proactive actions across organisations to manage and prevent escalation and reoccurrence. So really what we're saying in this particular recommendation is we want to embed housing risk prompts and routine checks across frontline services. We want to explore some models around a more coordinated single front door approach. And the other things that we've heard through the lived experience was that holistic nature that we're seeing at neighbourhood level interventions. So actually treating the person as a whole person and not just around maybe if it's about fuel poverty, but it's poverty in general. So this was really important to kind of encapsulate that in that particular recommendation. The fifth recommendation is building longer term resilience through income maximisation and onward referrals while strengthening our rapid crisis response. So we did really hear back from our lived experience interviews that the rapid crisis response was essential. Some people really are, during winter in particular, suffering from inability to pay their fuel bills. But actually what we want to do is strengthen this and actually match this with income maximisation and also looking at debt management. And one of the things that we found from the Stay Well network is that we've got various organisations doing a lot of good work, but in their area, and so we can't share that data. So there's some work around data sharing to ensure that they can refer on. So when we've identified somebody that might need some white goods, we can actually make sure that we've got the details of them and we can refer them on to people that can support them on their income maximisation work. And then we've got our sixth recommendation was developing training education programs to support guidance on reporting damp and mould across organisations and establish associated pathways for residents, professionals, including public sector and voluntary agencies. There are some excellent materials out there produced by our district and city councils around how to spot mould and damp and how to treat it. But we still do have people living in mould and damp conditions. And we're really hoping that with the Renters' Rights Bill coming into Act in May, that people will have more confidence to report their damp and mould. But we also need to be looking at pathways to help our social prescribers, our health visitors, anybody working in the community where they identify damp and mould, to understand that it is damp and mould and to know where to refer it to. And then our very final recommendation, we recognise that the needs of people that are living in non-traditional housing and inclusion health groups are potentially different from those in traditional housing. So those are your people living in caravans or boat dwellers. And the JSNA was very rapid, so we didn't really have an opportunity to really look into this in more detail. We feel that this is probably something that needs to be reviewed, and possibly all the pathways that go before and the recommendations before will help us inform some of the work that we can do with those communities. So you'll be pleased to know this is my very last slide. Just what I wanted to show you is that we have thought very closely around the next phase and the delivery phase. We've identified partners that can potentially lead on different areas. Working again collaboratively with the steering group, and these are very iterative in terms of the delivery phase. Recommendations will potentially have to happen first before we can move on to the next phase. So I think I'm being a bit ambitious with some of the timescales, but at least we've got a kind of program that we can start to aim for. So I just want to thank you all for the opportunity to speak to you, and if you have any questions, please can you just ask them. Thank you very much for your time.
Thank you very much, Kate. Members, any questions or comments on this item? Yes, please, Linda.
Sorry, thank you. This is excellent, and obviously something that we at Age UK, Cambridgeshire and Peterborough work quite heavily on. I apologise if I've missed this, but you said there's 15,000 households which are affected by damp in Cambridgeshire and Peterborough. Do you know how many people that actually affects?
So we've only got the 15,000 households, so we can't, and that's where we need to get the data. So one of the things that we're hoping to do now with the next data section is to really identify how many people live in those houses. But so it's an estimate, and it's an estimate from national figures.
Yeah, thank you.
Thank you, Kate. Dorothy.
Thank you very much, Kate. A really comprehensive paper which brings out the issue, and I did like well, not like's the wrong word. I found moving the story from an individual. Being cold and not being able to do anything about it is grim in the extreme, and that's what's being described for people we know. Your first recommendation is about the governance, and that feels right. But I'm wondering our role within that, and then how do we bring that back, and whether there's something about bringing back that description of your timescale as it firms up, so that we can both unblock things if it needs to be unblocked, but also help and understand what's being achieved. So I'm just wondering whether that could be an action, bring something back, and then guided by yourselves, whether that's 6 months or a year. It'd be nice if it was 6 months, and we can understand the momentum in this piece of work. Thank you.
Thank you, Dorothy. Okay.
Yes, thank you. Yes. So I think that what we'd like to propose is that we continue with the health and housing steering group to manage the delivery phase, but absolutely report back into the Health and Wellbeing Board on progress and if we have actually kind of come up with any blockers. I'm looking at Liz as well because she chairs that group. So-
Yeah, I think that's a really sensible approach. Thanks.
Thank you very much. Any further questions? Graham and then Erin.
Thank you for the presentation. Could you just clarify the role of landlords in all of this again? You've identified in recommendation 3 about maximising the opportunities for residents to access government funding or other funding sources, but will landlords not also be directed towards government funding? And is there a risk that that could increase the value of the property and then they put the rent up for the residents, which may or may not help all these issues?
So, so in terms of the landlords, obviously we've got two different types of landlords. We've got our private rented sector landlords and our social housing landlords. There is support for in the government's the Warm Homes project that they announced in January for landlords to make these changes and upgrade fuel provision within their properties. So we are hoping, we're waiting for more detail about when this is going to come out, but we are hoping that some of that will actually help our local residents. And our housing colleagues are doing a lot of work with the private rented sector landlords. And I think there's a conference in the next month with those landlords around actually what they can do to support residents. Social housing, there's been some specific work that's already been taken place in South Cambs around the oil-based people that are in fuel poverty around South Cambs area but are reliant on oil-based fuel. And so they've had some additional funding that's being provided to those particular social landlords. And we're hoping to see some more come out of the government's recent announcement that was earlier this week around communities that are facing kind of higher pressures because of the current issues abroad. So yes, absolutely, take on. I'm actually got further conversations with the social housing landlords forum next week.
Thank you, Kate. Erin.
Thanks, Kate. We also brought the JSNA to our South board on Tuesday morning and had a really good conversation about it, along with a paper from Cambridge City around the homelessness review. So it was a good kind of overall housing conversation. Just picking up a couple of bits that came out of that conversation, because conscious you weren't able to be there, Kate. The input from health. So I think we recognise that in the work so far in the group that Liz is chairing, we've maybe not had as much clinical input as we could benefit from. So we picked that up in board and talked about how we might get a bit more clinical input in there, and particularly joining up the different bits of the neighbourhood health guidance and the plans that we need to write. Some of the initial work we're doing in the south with Addenbrooke's around outpatients is very respiratory focused. So I think there's a good opportunity for us to find some ways to join that up in our neighbourhood health plans and get that clinical input, and importantly do the bit that you've carefully wordsmith recommendation for, but I would call intentionally opportunistic if I was doing layman's language, and the kind of finding some of those opportunities for getting things into primary care templates, things like that, as prompts and nudges. So we've got a few actions to take forward around that, which is really good. The South Place Board were really keen to be involved in that action plan. So I don't think we had that last slide you had up, Kate, but thinking through kind of what those commitments are and making sure we flow that through.
Thank you, Erin. And before you go there, just probably my question there too, which is, you mentioned by April 2026, we will have some form of database to share and cross-system database of platforms, so we can allow authorities to identify the risk household, they share information and data coordination to take action. Is that what's happening? Are we getting a single system? Are we just coordinating the ones we have?
So we're hoping on the data recommendation too that we're actually going to be looking at in the next 3 months to identify how we can actually see the individual households. And then we'll also be exploring a single front door opportunity that will still be robust against local government reform, because we're looking at some models at the moment with a single front door referral, that it's almost like a kind of front cover, and what goes on locally can still continue to go on, the pathways can still continue locally behind the door, but as far as your health visitor or your social worker is concerned, they just know that there's one place that they can call, one place that they can actually email, and then behind that something simple happens for them. I wanted to just respond on the South Place, and then I'll bring Ian in because he'd like to say something. So in regards to South Place, we're also intending to take this to North Place as well. We'll probably be taking it from a more delivery perspective because it's past this kind of consultation phase, having come to here. But yeah, it's really helpful to kind of hear your comments, Erin. And OHID have also worked on some respiratory with the clinical respiratory network, and have produced some guidance as well that we thought we would like to model. So I think that kind of joins up the clinical aspects that you highlighted a few minutes ago. Does Ian?
Yeah, thanks, Kate. So just this is a specific example from Peterborough, but brings in that clinical bit. So we've looked at GP lists and worked out those patients who have poorly managed respiratory conditions and top sliced those. So for the two practices, we've got roughly 500 patients that we were going to write to say, we think you might be at risk and we think it might be a housing issue, and therefore here's the help available. Unfortunately, the government changed the advice and support that was available in the budget. So the Eco4 program, which would have given them loft insulation or covered wall insulation, was stopped. That's now been replaced by solar panels and batteries, which is not a great help for those in the food poverty issue. But in terms of that clinical bit, if we can use GP lists, look at those people who might have a respiratory condition, and then match up with some of the data that Kate's looking at in terms of the housing conditions, that's where we have the win, because then we can target more specifically at a neighbourhood level those people in need.
Thank you, Ian.
I think this highlights one of my favourite hobby horses, which is joint up data. And I think here we need to take a view of how we have a data strategy. My aim has always been able to connect assisted bin collections with disease registers. And I post that everywhere I go, and everyone says it's really easy. And then when you come to it, it's actually really difficult. Now there's some really good stuff happening across the patch here. My appeal, Kate and Ian, will be that you link in with Nikki Ward, who's in the audience, around how we are moving on with data platforms from health, so that we don't miss that opportunity. So it's a supportive conversation, but we don't want to miss this at all in the new landscape. It's absolutely intrinsic to neighbourhood working to identify individuals, cohorts on the basis of risk. And I'm looking at Val and my public health colleagues around me here, that you identify the population and you do the evidence-based intervention. So to do that, we've got to have the joined up data. So let's keep close on that.
Thank you, Pam. Yeah, that definitely is paramount. Any further comments? Thank you very much. We will move to the report recommendations. The Health and Wellbeing Board and Integrated Care Partnership is being asked to support the following in the joint strategic needs assessment: the strategic themes and findings, and to consider and note the contents of this paper and strategic recommendations under deliverables identified in the JSNA. I will take that the board is happy to support these recommendations unanimously. And we move to item number 7. Item number 7 is the Peterborough City Council Annual Director and Public Health Report 2026-27. The report will be introduced by Raj Laxman, Acting Director of Public Health and Peterborough City Council. Raj, I'm going to be very rude and I'm going to ask to be concise.
Yeah,
Thank you.
I think there's just 5 minutes left. I will be very brief. So we talked about the obesity charter. We know physical activity is one part of it, and so this report is about physical activity, and it talks to communities and our residents about how to improve physical activity. It's a statutory responsibility for directors of public health to do an annual report. And this report is called Spring into Action, the race to get Peterborough moving. It will be accompanied by a year-long Peterborough Get Moving campaign, which will have videos and vlogs and case studies and patients talking about how physical activity improved their health and various other community activities going on. So it's trying to get everybody to move. And it follows on from the CMO reports, which talked about physical activity being a miracle cure. So we want to inspire everyone to be more active. There's inequalities in physical activity. There's a lot of data, and we're not expecting people to read all of it, but it takes you through various stages. It talks about why physical activity is important. It talks about the recommendations, which is the on your marks, and it shows data about reduced healthy life expectancy in Peterborough. The main contributor for reduced healthy life expectancy is musculoskeletal disorders and mental health, and physical activity helps with both, not just obesity, but also these wider benefits of physical activity. And Section 2 describes all the benefits in terms of long-term conditions, and it reduces our chances of dying early and increases the number of years we live in good health. And Section 3 gives key messages in troubleshooting and help so that people can get more active. Thank you.
Thank you, Raj. Members, any comments or questions? Dorothy and Pam.
Raj, thank you so much. Thank you, Chair. It's just great to read the positivity in this report, and also the way you've described the barriers to people and how unpick that. And I love the quote about if exercise was a drug, it would be a miracle. It is absolutely so important to us all. I think you described the campaign, Raj, and my question is how can we help? How can we multiply that? Because getting the messages out is going to be key. But I think you picked a really positive topic, and thank you. And we heard earlier about the obesity being one side of the coin, and then this is a really positive side where people can embrace and make a difference. Thank you. So it's about how we can help with the campaign.
Thank you, Dorothy. And yeah, I think we are looking for volunteers to talk about their experience of how they've improved their health by doing physical activity or any sort of, we're going out to community groups, we're going out to yoga classes and old care homes and children with disabilities. So we're doing a lot. Every week there'll be something produced by the Peterborough Comms team. So yeah, if you're happy to be contacted to be part of a vlog, we call them 1-minute videos, so vlogs, which we'll start on the 25th of March when our leader will do the introductory vlog, and then we'll carry on with various patients and other community groups.
Chair. And also think about us as organisations, how we can amplify your message.
Pam.
So I'm very happy to ride shoulder to shoulder with Raj on this one. I feel absolutely passionately about how this is a galvanizing approach, non-prejudicial approach to our communities that will actually enable many of the things we've talked today about to come to fruition. The way that you start to get communities physically active is not by telling them how to do it. It's about generating what you said, Chairman, about owning the issues around obesity. owning an issue about physical activity and us working through the barriers. So again, the solution to this is about neighbourhood activation. I think we can bring many of our voluntary sector community leaders and local champions into this space. But what I'd like to see, having worked with Dr. William Bird previously on this, is physically active champion GP practices. That made a huge difference where I've worked before. Neil's already articulated it, but that's not ubiquitous across the offer. So we need to see with Peterborough colleagues, and I'd like to see it happen across Cambridgeshire as well, is how do we start to get that first line prevention and dialogue into the front door of general practice. Many years ago, people scoffed at the idea of a green prescription, and now the benefits of being outside to young people, elders, everything is well understood, as is the reduction of social isolation. If you could do anything, you create community groups, physical activity groups, you are going to hit reduction of social isolation in a more sustainable way than we can ever purchase. So this has to be a cross-cutting approach, is my belief. So thank you for bringing it. I willingly take on the challenge and support you. Most places I've worked before, I've usually had a QR code on my back wherever I've been about physical activity, things whenever we're doing publicity. So we need to brand it. We need to all resonate it, and we need to make sure that we've got the physical activity leadership multi-agency as well. It benefits, you know, the statement from the CMOs is very, very clear. It's a wonder drug.
Thank you very much, Pam. Absolutely. It's incredible. Just to highlight how good the report is. And I don't want to oversimplify walking. Let's get, especially with the elderly population, walking. I have a personal experience. My dad is 88 today. This year. 5 years ago, he was ready for full-time care, and he required a little crash course on physio. But other than that, is walking. Today, he's absolutely fine. He lives his life as normal, and it is all because he managed to get himself moving again. And that is, it's not a panacea, but it is very, very important. So, one more comment. Yes, Neil, please.
Thank you, Chair. Comes back to my colleague, actually. I've actually spoken to Raj about this prior to this. And we already have spoken about using the community champions, but also ward councillors. And one of the other ones is parish councillors, because they're in touch with their residents much more than ward councillors. So we've already discussed this, so things are actually happening.
Terrific. Thank you very much. Members, I guess we move now to the report recommendations. The Health and Wellbeing Board and Integrated Care Partnership is being asked to approve the launch of the 2026-27 Annual Director of Public Health Report, which aims to increase physical activity among all Peterborough residents and to embed increasing physical activity in the integrated neighbourhood health plans. And consider what board members, member organizations and partners can contribute to need reduction. No, I'm reading that different. Sorry about that. I'm reading the previous point. I'll take the board is happy to support these recommendations unanimously. And we move to item number 8, which is the Integrated Care Board reconfiguration. This will be presented by Pam Green, Director of Neighbourhood Health, Place and Partnerships for Cambridgeshire and Peterborough, ICB.
Thank you, Mr. Chairman. I will take this paper as read in the interest of time so that we can move forward to questions where needed. It's very pertinent that we talk about this now because we're on the cusp of the reconstituting of integrated care boards on a very, very different footprint, following all the announcements in March 2025 where ICBs were to reduce their running costs by 50%. On that note, I would like to make colleagues aware that that process has been difficult. and continues to be very distressing for people that have contributed a significant amount of their working life in the NHS to go through this process at the moment. So I ask for kindness as they interact with our organisation, because actually we are seeking to support our staff, and for those that are leaving the organisation, enable them to leave well, and for those that remain, to ensure that they feel less of the survivor guilt than is currently being articulated when the scale of the loss within the organisation is so significant. We do need to work in a very, very different way going forward with the reduction of workforce that we will see. Our priorities absolutely are about neighbourhood working, because that's the biggest shift that has been articulated in the new ways of working. And as has been referenced today, the guidance and the contract opportunities were issued this week. So it's all very current. The organisational size come the 1st of April is the responsibility of Central East ICB, covering 3.5 million population, with a significant budget that aligns to that. Now, for you in Cambridge and Peterborough, I will be your representative, hence why I'm here today. And the commitment of the executive and the management team is absolutely to keep that local focus. And that isn't necessarily how all ICBs have taken this challenge on. So we're absolutely committed to the neighbourhood way of working. We've enabled a layer of director level responsibility and autonomy that you see represented in myself here to move that agenda forward. We have had to develop a strategic commissioning document and to enable us to redefine our challenges and how we work with place leadership, etc., that you've heard articulated today. And that is referred to as our way, and we will ensure that if it hasn't been circulated, it will be circulated very soon, and it will be a public document. It basically articulates our relentless focus on our experience of our citizens to navigate the health service, for it to be a responsive but connected service, and for us to achieve financial sustainability, have a thriving workforce, to ensure that we're making the right contacts happen at the right point in someone's pathway, and that we are supporting individuals to keep economically active, because we know that is the single biggest connection to citizens' outcomes. So they are not challenges that we can face on our own. I think you have seen through today's agenda that we are absolutely hand in glove with these challenges. And I think, you know, we've got a joint strategy, we've got joint governance. I think we're in a much better place than many other areas to take this challenge and move forward. So I won't say any more. I will move to questions if there are some, but hopefully you will see that whilst we're going through this very heavy legal and HR process to establish ourselves by the 1st of April, the continuity of working with you as multi-agency is absolutely there.
Thank you, Pam. Questions, comments to members? Patrick.
Yeah, thanks, Pam. And we understand how challenging it's been for you as partners, not just you personally, but for you as an organisation, for the significant change you're going through. I suppose 2 bits. One is, when the blueprint came out, there were certain aspects which were, as partners, we weren't clear on, and we're still not clear on, one around safeguarding and one around kind of SEND and children's services. So it would be helpful to understand, maybe not today, but just where that is. And I know some of that is delivered through primary legislation changes, etc. The other bit is, which is natural when you're going through such a major change, is we're losing key contacts as organisations to build that partnership. It's good that we've got you, but it's just, it will help us in the medium term, excuse me, to understand how those new appointments are then falling in, and for us to start making contacts and build those relationships up, because we've certainly felt the loss of, and you must have felt the loss of, a lot of historical knowledge and key people who we'd built relationships up with, and we've lost those. So Just 2 points there.
Yeah, so I think it's fair to say that the blueprint was slightly muddled on safeguarding. I don't think I'm saying anything politically insensitive by saying that. And I think we continue to work with our statutory responsibilities around safeguarding, and we must work in the best interests of our population. So we are undertaking that. We're constantly looking at what the safeguarding guidance is looking like, but there is no break in that responsibility at the moment. And you know, that's our duty of care to ensure that we safeguard our population. Continuity and contacts is tricky. I'll be completely honest. We are losing talent and we are losing historic knowledge, but we are also going to ensure that people leave well and they hand over. And I think what's really important for partners is that we share as soon as we have our, you know, organizational structures and our grids of where people are and what their responsibilities are, that we share that really, really openly with you. And where you have a debate as to who is my responsible officer, that you come to me and my team and we will navigate through that for you. So we will be working on a matrix approach. So the directors that have responsibility across Central East that have things like safeguarding that pour into our neighbourhood and our locality will absolutely be accessible through myself.
Thank you. Anybody else? Andrea, please.
Thank you. Thanks, Pam, for the report. I think it's fair to say we already have a fantastic working relationship, the Combined Authority with the ICB, and the strength of the partnership in the creation of the Get Cambridgeshire and Peterborough Working Plan was certainly noted. And also the work that has been undertaken to connect work well with Connect to Work is certainly proving to be really beneficial. So I just wanted to offer my continued support, and if there's anything we can do to kind of help in the interim, then please let us know. Thank you.
Thank you very much. That support is welcomed and will be taken up. And I am absolutely clear that the work well is our blueprint here and is exactly how we want to roll out greater neighbourhood and multi-agency working. And I think we should unpick what made that so successful. And some of that is about, you know, how the Combined Authority came to the table and galvanised some of the work. But it's also about that grassroots approach and looking at the voluntary sector and the contribution from the community. So we've got to do top down and bottom up in this approach, and let's role model that for the future.
Thank you, Pam. Anyone else? Dorothy?
Just very quickly, I wanted to echo what Pam had said about the professionalism of staff who have worked really diligently to make sure the ball hasn't been dropped through that time. But I think that has come at, you know, personal cost as always when people go that extra mile. And to reiterate what Pam has said, is there any concern that the ball's been dropped or there's issues, do contact Pam or myself. We may not be able to solve it quickly, but we need to know about it and understand how best we can help. Thank you very much.
Thank you. And if I could just have one more point, which I forgot to outline, is that we will be having a neighbourhood delivery committee that the local authorities will be partners with us on. And that will give us the localised governance that reports into the bigger Central East approach. We've got a combined chairing approach with local authority leaders and Dorothy as a non-executive, so that we can keep the voice of the population really loud in what we're doing. And with my colleagues from Public Health, Raj and Sally, leading on that, what does it mean for neighbourhoods, so that we're really connected. And that committee will oversee delivery and enable us to bring things more shaped, more assured to here, and that connection to the Health and Wellbeing Board will not be lost. So hold us to account to deliver, because that's exactly what we're here for.
Thank you, Pam. And just to do so, are there any specific services or functions that are expected to be reduced or merged? And have we got the impact assessments and on those that we should know now?
services generally because of the
Specific,
change. Yeah. So no, it's not currently, because we are transitioning an organisation at the moment. So actually, what we're not able to do is go through assessments on risk of should we stop things. We will, in the fullness of time, have to look at the best practice across the whole of Central East and say, actually, can we do better in some areas? But this is a transition of current arrangements into a new organisation, and then we go through the joint commissioning discussions and what best serves our population. That isn't what this restructure is doing at the moment.
Thank you very much, Pam. We will move to the report recommendations. The Health and Wellbeing Board and Integrated Care Partnership is being asked to acknowledge the current position and future plans of the ICB Central East arrangements. I will take that the board is happy to support these recommendations unanimously. And we move to item number 9. Item number 9 is the governance and member update. Please note that members whose membership is being discussed in the report should abstain from voting on this item. This includes Pam Green, Dorothy Gregson, and Dr. Neil Moda, who's not here now, and Paul Mead, who's not here now. This item will be introduced by Kate Parker, Public Health Principal, Social Determinants and Health at Cambridgeshire County Council.
Thank you, Chair.
Thank you.
So it's a very simple paper. It's just basically proposing revisions in the terms of reference for the joint Cambridgeshire and Peterborough Health and Wellbeing Board. There are 3 main areas as to why we're doing this. The first is following on from what Pam's just said. It's in relation to the membership changes for the ICP as it changes to a Central East team. The second changes that we're proposing are as a result of the committee being a committee in common with the Integrated Care Partnership and the Cambridgeshire and Peterborough Health and Wellbeing Board. As a committee in common, there are some shared memberships, and the ICP has changed its status, so that's the Integrated Care Partnership, to a non-statutory requirement. So because some of the members of the committee in common, so the 2 ICP and Health and Wellbeing Board, are only ICP members and therefore non-statutory, we're proposing to move those membership over into the Health and Wellbeing Board, which is a statutory membership. And then the final changes is the additional inclusion of place leadership, so from North and South, and also an extension to the membership of the Health and Wellbeing Board that includes both the executive directors of adult social services and directors of children's services from both Cambridgeshire County Council and Peterborough City Council. And that's in reflection of the new responsibilities that the Health and Wellbeing Board has around neighbourhood health plans. So that's a summary of the governance changes.
Questions or comments from members? No? Pam?
Just thank you for moving so swiftly to accommodate our changes, and I'm a willing participant, and hopefully that will be sufficient to assure people if this is the right direction.
Thank you very much, Pam. I have the report recommendations as stated in the paper, and I'll take that the board is happy to support these recommendations unanimously. Thank you very much. We move to item number 10. Is the agenda plan with Democratic Services Assistant? Let us know if there are any changes to the published report.
Please can members note that the dates included in the agenda plan are provisional. Members will be updated later in the month once they've been confirmed.
Thank you so much. Any comments or questions on that? No? We will note the agenda plan. Thank you very much for attending today, and I declare the meeting closed. Thank you.
Can I quickly just say, so for those that hopefully most of you are staying for the development session, which is due to start at 1:30, which doesn't give quite enough time probably to people to grab lunch and things, but what do you think, Pam? Can we just 20 minutes?
Yeah, I mean, I think
as minimum time as possible, 15 minutes.
Sally, we're still live streaming, so we can probably have this.
Apologies.
Yeah.
Okay. Yeah. 15 minutes if possible, please, and then we'll get started on the development session. Thank you.
Thank you.